1. Okay, so this is term 3 boot camp. We're going to go over med templates, and we're going to go over all medications for pharmacology 1, weeks 1 through 6. So let's get started. I'm going to share my screen. And the first thing I'm going to do is I'm going to show you a medication template. So this medication template just happens to be digoxin. You put your name in, right? Then you put in the name of the medication, digoxin. Okay? And then the classification of digoxin, it's an antiarrhythmic. Okay? And that is spelled absolutely incorrectly, but whatever. Pharmacological action. You can put it there, you don't have to. Digoxin, I talk about this a lot. You'll see when we get to it. It makes the heart beat slower. So it slows the heart rate down and it makes it pump more efficiently. Okay. Therapeutic use, most often heart failure and AFib. Okay. And this is information that you will find in my lectures, in my PowerPoints. Complications. Again, you can't know all of them. So you have to concentrate on the ones that I talk about, right? And I will talk about this a lot because dig is the queen mother of the cardiac meds. Dig toxicity. So any serum level greater than 0.8 to 1.2 is toxic. Early signs of toxicity: anorexia, which is loss of appetite, GI upset, bradycardia, dysrhythmias, blurred vision, green or yellow halos around objects in the visual fields. The antidote is Digibine. So those are the complications, okay? Contraindications, precautions. You're always going to take the heart rate apically for 1 full minute. Anything less than 60, greater than 100, you're going to hold the drug. And hypokalemia is a risk factor for toxicity. So always use it cautiously if the patient has a history of hypokalemia. So when you look at these complications and contraindications, they're telling you what you need to put in the nursing interventions and the client education. They're telling you, okay? So for nursing interventions, if toxicity is an issue, well, how about check serum dig levels? Check serum dig levels, and they should be 0.8 to 1.2, right? That's an intervention. And what other interventions? If hypokalemia is a problem, how about check potassium levels? Check serum potassium levels, right? And they should be 3.5 to 5.0. And then under client education, well, what do you have to teach the patient? Don't you have to teach them all of this? Don't you have to let them know that they have to get blood work, right? That these are signs and symptoms. So I'm just going to copy what I already wrote, right? And then down here in client education, I'm going to paste it, but I'm going to put in here, instruct patient, lab work is necessary. And here's why, right? Because they can become toxic, all these things, serum levels, blah, blah, blah. Here are the signs and symptoms they should know about. So if they experience loss of appetite, GI upset, they feel palpitations, they see blurred vision, or they see halos around things, they need to not take the drug and call the doctor, right? So whatever you're writing in complications, contraindications, there's going to be something about them addressed in your nursing interventions and your client education. Please don't write, take the drug the same time every day. Okay, all right. And then under interactions, what drugs interact? The big thing with dig is that because hypokalemia is a risk factor for toxicity, any drug that makes them potentially lose potassium, you're going to be cautious about. So the diuretics, which are furosemide, bumetanide, any drugs that deplete potassium, use cautiously. So this is the way you fill out these forms. You do not copy and paste anything from anywhere, because I can tell if you wrote it in your words versus pulling something from a textbook or from online, okay? And when it comes to these meds, any med really, you must look them up in F.A. Davis, the drug book, since we're having difficulty with the online resource, okay? That is the only way to do these meds. If they were done any other way, you're going to wind up having to redo them. Because if you do this the way I'm showing you, and you go by the PowerPoint that I give you and the things that I talk about, when you get a test, you're going to go, all right, I remember DIG. They have, DIG toxicity, blah, blah, blah. So there's going to be a question. You're taking care of a patient who has an order for furosemide and digoxin at 0900. Which of the following statements by the client would make you contact the healthcare provider? And the right answer would be the client complains of nausea and vomiting, because that could be DIG toxicity. All right, so we're going to take a quick break, and I am going to do a Q&A with the class that I have. Okay, so now we're going to go through the medications. Going to start with chapter 6 and work our way through. So I will share my screen, and here's my PowerPoint for chapter 6. Chapter 6, antibacterial drugs, antibiotics, in other words, particularly sulfonamides. Okay, so when we look at this PowerPoint, what are they? They're antibiotics. They're effective against bacterial infections. They are not effective against viruses. No antibiotic works on a virus. Must know meds. What do you got to know? Sulfamethoxazole, trimethoprim, and sulfasalazine. They're the two. And when I have things highlighted like controls urinary tract infections caused by certain bacteria, you know that that's the big use for that drug, for those drugs. Those two medications are mostly used for urinary tract infections. Okay? Adverse reactions, GI upset, which is all these things, anorexia, nausea, vomiting, diarrhea, abdominal pain, chills. The urine and skin will take on an orange yellow color. That's not abnormal. It's expected, right? So the things that are highlighted here, you would put on your med template. All these things, right? Crystalluria. In other words, if they don't take in enough fluid, they can wind up having crystals. It looks like crystals in their urine. They got to take in enough fluid. And photosensitivity, sunscreen, protective clothing. That's what they need to wear so that they don't get a sunburn, because they're going to be more prone to a sunburn with these drugs while they're on them. So when you go through it and you look at things that aren't highlighted, you say to yourself, can't be all that important. But then you come to this and see it's highlighted. When they're on sulfonamides, they can get thrombocytopenia, aplastic anemia, and leukopenia. So if you don't know what those things are, then you need to look them up, and I'm going to tell you. Thrombocytopenia, low platelet count. Aplastic anemia, low hemoglobin. Leukopenia, low white blood cell count. And so if they're on these drugs, they're at risk for these things. So you, as the nurse intervention, need to be looking at the labs. What's their platelet count? What's their hemoglobin? What's their white blood cell count? Are they normal? Are they low? See how easy? Okay. Understand their sulfa drugs. So if the patient's allergic to sulfa drugs, no, can't do, can't have them. Okay. And if they have any renal problems or hepatic problems and asthma, you're going to be very careful. So another nursing intervention, look at the labs for renal and hepatic function. BUN and creatinine for renal, AST, ALT, bilirubin for hepatic. Renal's kidneys, hepatic is liver. When we get to drug-drug interactions, when I have them highlighted, they're the ones I want you to know. Warfarin. If you're taking warfarin and then you take one of these two sulfa drugs, it's going to increase the action of the warfarin, so you're at risk to bleed. If you take the sulfa drug while you're taking methotrexate, it's going to increase bone marrow suppression, which means you're really at a risk for low white blood cells, low red blood cells, hemoglobin, and low platelets. And if you are taking an anti-seizure medication, phenytoin, which that's one of the hydantoins, then you're going to have an increased serum level of that. So you're at risk for toxicity with the phenytoin. The things that I'm highlighting are the things you need to know. So all these things aren't highlighted. I'm not saying don't read the nursing care plans, blah, blah, blah. But what I'm saying is I'm giving you your study guide. These are the things that you need to know. There you go. Photosensitivity, right? There's leukopenia, thrombocytopenia, even nursing interventions for them. Okay. No highlighted, no highlighted. Very easy. That's the end of that chapter. Okay. Easy peasy, lemon squeezy. Okay. Let's close that bad boy out And now we're going to move on to the next one, which is going to be chapter 7. And that is right around the corner. Chapter 8, chapter 7. Okay. Chapter 7 is antibacterial drugs that disrupt the bacterial cell wall. Who cares? Right? Who cares about that? Here's what you need to care about. What meds are we talking about? Penicillin G, the cephalosporins, and Vanco. Boom. Penicillin G, cephalosporins, which they all start with Ceph, C-E-F, or C-E-P-H. Okay? And then vancomycin, the queen mother of antibiotics. It's used to treat MRSA, other things as well. When it's given IV, it's got to be over 60 minutes or longer due to an adverse effect potential called red man syndrome. Patient will begin to flush and become warm, okay? And they'll become hypotensive, some other things too. So again, when you're looking at this, Miss Mary doesn't have anything highlighted here, but here, this is highlighted. So this talks about drug resistance. Vancomycin is one of the ones used for MRSA, which is a superbug. So what is drug resistance? Drug resistance is an issue when somebody uses antibiotics regularly, too much, right? Or a group of people that live in close quarters, like hospitals, nursing homes, okay? Bacteria can become naturally resistant or acquired resistance to drugs. MRSA is that. Methicillin resistant Staphylococcus aureus, okay? And so emergence of a new resistance associated with bacteria that have both a natural and an acquired resistance ability, like MRSA. So in other words, overuse of antibiotics, misuse of antibiotics, particularly the ones in this section, penicillin G, cephalosporins, right, can cause these drug-resistant organisms. Vancomycin, the queen mother, is the one that can treat, thankfully. What are the adverse reactions to penicillin? Here you go, pseudomembranous colitis. Well, they can have anaphylaxis, of course, or they can have hairy tongue, or a superinfection, like a fungal infection like candidiasis, okay? So when you're looking the drugs up in the drug book, there's a whole lot of stuff, but here are the bullet points. Boom, bada boom, 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 right? They can get hemolytic anemia, agranulocytosis / neutropenia. So these drugs can cause, well, all the penicillins, amoxicillin, penicillin, can cause a problem with red blood cells. Hemolytic anemia is where the red blood cells self-destruct, and then low white blood cell count, which is agranulocytosis and neutropenia. Okay, we talked about the hairy tongue, which is fun, and then candidiasis, which is an opportunistic superinfection. Okay, right there. Nothing highlighted here, nothing highlighted here, but look at this. What are they used for? The cephalosporins? They treat the same stuff that penicillins treat and some that penicillins don't, but they're used often for UTIs, bone and joint infections, respiratory infections, ear infections. Boom, right? There you go, ba, ba, ba. Nursing alert for the cephalosporins. Oh, look, if you're allergic to penicillin, you're allergic to the cephalosporins. So there it is. And look, there it is again, which tells you that that's got to be important, right? And then use cautiously in patients that have renal disease, hepatic impairment. So in other words, it's the kidneys, it's the liver, the kidneys, the liver, kidneys, the liver. They excrete all drugs. So you're always going to be checking those labs. Be careful if the patient's pregnant. And of course, if they're allergic to penicillin, that's a problem with the cephalosporins. What else do I have? Here we go. Vancomycin highlighted. Do you need to know about the synthesis? Not so much. You know how the action of the drug is. But the things that are highlighted are the ones that you need to know, right? Cephalosporins have a nephrotoxic effect. In other words, they can really hurt the kidneys. That must be important. That's highlighted. So an early sign of it is decreased urine output. Make sure you're measuring the fluid intake and output, and make sure you're noting any changes in fluid intake or output ratio. In other words, if they're not peeing as much or their urine looks dark or cloudy, they could be getting a problem with the kidneys That's nephrotoxicity because of the cephalosporins. Right? There you go. If they're having diarrhea with these drugs, you want to make sure that you're looking at the stools, because if the stools have mucus or blood tinged in them, then it could be pseudomembranous colitis. Look for superinfections like candidiasis, right? All these things are important. Inspect the patient's mouth, hairy tongue, frequent mouth care, soft bristle toothbrush, soft diet, watch what they're eating. And if they're having severe symptoms, you can give them something for fever or for the fungus. Candidiasis requires nystatin, swish and swallow. Okay. And then educate the patient and the family, right? And stay away from alcohol with these drugs particularly. And how do you know that it worked? Well, therapeutic drug effect is achieved. What does that mean? If I'm giving you a drug because you have an infection, is your infection gone? Then the drug worked. It's that simple. And then at the end of this PowerPoint, you've got questions and answers. So that's it for that one. I'm going to stop sharing for a minute and see if anybody has any questions. Okay, we're back to recording. We're going to move on. Chapter 8. I'm going to share my screen. Chapter 8, another antibacterial antibiotic. Okay, what are these meds? I don't know. Let's take a look and see. Tetracyclines. Okay. You see, I don't have anything highlighted here because you really don't need to know all of this, right? Again, a lot of the same. All antibiotics can cause GI distress, all of them. But here there are things highlighted. Well, don't give it to people allergic to it. Don't give it when they're pregnant, and don't give it to children younger than 9, 8, 9. Why? Tooth discoloration. That's permanent. And that's the one thing with the tetracyclines that I emphasized a lot, because if you're going to get a question about them, that's probably what you're going to get asked about. And then with the mycins, all the other mycins, what are the adverse reactions? Erythromycin, tobramycin, gentamicin, mycin, anything that ends with mycin. Yeah, nausea, vomiting, anorexia, rash, urticaria, but all the mycins are nephrotoxic, ototoxic. They can be neurotoxic too. But even in my lectures, I go over that again and again. All of the mycins, nephrotoxic, ototoxic, nephrotoxic, ototoxic. Nephrotoxicity, damage to the kidneys, ototoxicity, damage to the hearing. And they're the things that you want to know about the mycins. So when you have a patient that's on them, you would tell them, you develop tinnitus, ringing, buzzing in the ear, you stop the drug and call the healthcare provider, because tinnitus is a clinical manifestation of ototoxicity. And if we damage the patient's hearing because of the drug, it's permanent. We can't reverse it. And then the nephrotoxicity, right? The same thing. If decreased urine output, the urine's concentrated, it smells, it's cloudy. They're not peeing as much as they used to. You're going to be worried about kidney function, right? So the things that are highlighted are the things that are super important. The nursing process. Here you go. Tetracyclines, empty stomach, full glass of water, okay? Do not give with dairy products or antacids or laxatives. So when that's highlighted, you should know it, okay? Empty stomach, full glass of water. Don't give with a glass of milk, right? Don't give with antacids or laxatives or products containing iron. So the things that are highlighted, again, bing, bang, boom, 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 are the things that are important. And tetracyclines are the bacteriostatic drug used when the patient is allergic to penicillin or cephalosporin. Is it true or false? It's true. So if you're allergic to penicillin, then you're probably allergic to cephalosporins, but I can give you the tetracycline. And that's it. Those are the things highlighted in that chapter. We're done with that chapter. Close that bad boy out, okay? Now we want to go to chapter 9. Chapter 9 is the fluoroquinolones. Let's open that bad boy up. Make sure that we've got this shared. Chapter 9, the fluoroquinolones, okay? And when you hear that, hopefully your brain goes up, Cipro. And you see there are others. They all end in floxacin. But here's the highlighted one, because that's the one that you will most commonly be asked about. But if you're taking a test somewhere down the road, once you get out of LPN school and you get past your boards, when you see floxacin, it should trigger you to go, wait a minute, ciprofloxacin. So this must be an antibiotic that's in the same family. See? Okay. So Cipro is the one that you need to know. The two things that you need to know about Cipro, it's used for anthrax. It's going to come in handy in term 5 when we talk about disaster. And it's also used for UTIs and skin infections. If the patient isn't on sulfamethoxazole trimethoprim for a UTI, they're probably on Cipro. Okay, that is the one. And this one I have highlighted in purple. Serious adverse effects, tendinitis, Achilles tendon rupture. So you know you want to put that on your med template because clearly that's something that you need to know. Okay, here you go. Some other useful information. Always take a culture and sensitivity before the first dose of the drug is given. And you're always going to be looking at renal and hepatic function tests, CBCs, urine analysis, right? So those are nursing interventions for almost every drug out there, almost every drug out there. And then we have some nursing diagnoses, blah, blah, blah. And then here's a question at the end. Again, this is important. It's highlighted. Following statement, true or false? Frequent liquid stools may be an indication of a superinfection or pseudomembranous colitis. That's true. Frequent liquid stools may be an indication of superinfection, pseudomembranous colitis if it occurs, it's seen 4 to 10 days after treatment is started. And that's important to know, right? For all of the antibiotics. So, you know, when you're looking at these PowerPoints and you're listening to lectures, the things that are highlighted are important. So there's chapter 9. Now we want to go to chapter 10. After chapter 12, I'm going to take a break, but let's try to get through this. So chapter 10, let's get to that, is the anti-tubercular drugs. These are drugs that are used to treat tuberculosis. Okay? And there's 2 of them. You need to know, isoniazid and rifampin. And I highlighted them and I put rifampin red because that's the one of the 2 that's going to turn body fluids like urine, sweat, saliva, and tears a reddish orangish color. So, and the patient needs to know that. And then here, always used with other drugs to treat active TB. The exception is isoniazid. So in other words, you're always using 2 drugs. And I go on and say standard treatment is 2 drugs, always, right? And in my lecture, I talk about the reason for the 2 drugs. The reason for 2, not 1, is not to decrease the spread or the transmission of tuberculosis, but it's to make sure that you're covering any resistant strains of that tuberculosis bacterium, okay? And sometimes if the retreatment is required, we're going to use 4 or more drugs to treat it, okay? Reactions, nausea, vomiting, blah, 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 right? If they're toxic, these 2, I mean, this one is very important, peripheral neuropathy. In other words, peripheral, meaning feet and hands, arms and legs. Neuropathy, there's a problem with nerves. So it's a loss of sensation or numbness, tingling in the hands, fingers, or feet, toes. And so that's a problem, something that you need to know. Here I do have a drug interaction highlighted because it's important to know that anticoagulants, any of them, which we haven't gotten to yet, but we will, if they're on them and isoniazid, then they're going to have a big risk for bleeding. Okay, that's important to know. And then here, reddish orange discoloration of body fluids. Very important. If you're going to get asked about rifampin, that's probably going to be what the question is about. And then you also need to know that you got to be careful if the patient has renal problems or if they already have a hearing problem, because nephrotoxic and ototoxic, rifampin too, right? So clearly that's important. So you would want to know that. And then when you look at the rest of the PowerPoint, there's not a whole lot. Matter of fact, there's nothing else highlighted. And so that's the important stuff for those drugs. So now we're going to go to chapter 11, which is, and where's 11? We're getting there. 11 is the antivirals. And there's only one med. One. Boom, boom, boom. Acyclovir. Okay. And it's nice because it ends in VIR and virus starts with VIR. So that's the antiviral med. What is it used for? Viral infections, right? The only reason I have this highlighted here is because with this type of drug or this particular drug, it's used to treat the herpes, which includes herpes 1, herpes 2. Herpes 1 is the fever, blisters, cold sores. Herpes 2, the gift that keeps on giving, genital herpes. Herpes zoster, shingles. HIV, influenza A and B, respiratory. These are viruses that you will need to know about in term 5. And so I highlighted them now and we will revisit them in term 5. But the reason that you need to know this is that so you remember viruses, treats viruses. What are the side effects? GI mostly, right? GI mostly, which they all can give GI side effects. Who are you worried about in giving the drug? Well, if they have a renal problem, if they have low blood cell counts, in other words, white blood cells, red blood cells, thrombocytes, a seizure history, epilepsy, or a history of respiratory disease. You do have to be careful. Doesn't mean don't give them, it means give them cautiously, right? And that's acyclovir. Because antivirals cannot kill a virus, they can't stop a virus, they can't cure a virus. What they do is they can slow down the progression of the virus and they can minimize the symptoms. And I talk about that in my lecture. With nursing diagnoses, body image disturbance. Why? Because if you got the herpes, you probably have an issue with body image. People tend to be very self-conscious, okay? If they have cold sores, fever blisters, whatever you want to call them, that's herpes simplex 1. And then there you go. So that takes care of that. And last but not least, with this set, I'm going to go to PowerPoint 12, chapter 12, which is, there's a fungus among us, antifungals and antiparasitics. And I don't get into details with this category. Why? Because you're not going to need to know a lot. What you're going to need to know, let me make sure I'm sharing the right screen. Okay, this is chapter 12, antifungals and antiparasitics. For antifungals, you have to know nystatin. It's the treatment for candidiasis, nystatin, swish and swallow. Okay, that's the big one, right? So they're fungicidal, fungus that they kill fungi, not a fungi, but that's multiple fungus, right? And not going through all of this, right? You see anything else? There's nothing else highlighted. The reason being that we could go on and on with this particular category, but you're not going to get asked a lot of questions about it, okay? And when we talk about antiparasitics, talking about things like scabies, lice, not a whole lot really that you need to know about that just yet, okay? Because there's enough for you to memorize and understand in this term. So I don't get into great detail with this chapter. And that's the end of that. I am going to stop my sharing and I'm going to pause the recording and see if we have any questions right now. Okay, we're back. Now we're going to get through chapters 13, 14, 15, and 16. So let me share my screen. And let me clear my throat. All right, 13 is on non-opioid analgesics, the salicylates, and the non-salicylates. And that's a fun word, salicylate, okay? It really is. So the 2 drugs you got to know, aspirin, acetylsalicylic acid, AKA the salicylate, and then acetaminophen, also known as Tylenol, okay, which is a non-salicylate. Well, what do you need to know? First, I talk about pain because it's important to understand that these drugs are analgesics. In other words, they relieve pain. What is pain? I talk about pain is whatever your patient says it is, right? And is it acute or is it chronic? Acute pain, short and hard. Chronic lasts usually more than 6 months, okay? That's important to know. Salicylates, we'll start there. That's aspirin. They are good for pain management because they're analgesic, antipyretic, they reduce fever, and anti-inflammatory, but they're not an NSAID. Okay, they're not an NSAID, they're salicylates. Okay, aspirin, greater inflammatory effect, right? But it prolongs bleeding time. And that's important to know. It's highlighted. So what do we use it for? We use it for mild to moderate pain, reducing fever, treating things like osteoarthritis, and then decreasing risk of a heart attack and a stroke because of the fact that it prolongs bleeding time, prevents the platelets from sticking together. What do we need to know about adverse reactions? GI, upset, heartburn, nausea, vomiting, GI bleeding. And that's a big one, right, that you need to know about. Very important here to know, don't give it to a kid if they have a viral infection because it can cause Reye syndrome. And I even give you guys an explanation of what Reye syndrome is. I save you the trouble of looking it up. See, you're welcome. And then use cautiously. Hepatic or renal disease, again, it's the liver and the kidneys and the kidneys and the liver. Use cautiously during pregnancy, lactation, any pre-existing hypoprothrombinemia. When you see that, you're going to go, what's that? Look it up. Hypoprothrombinemia means a low prothrombin time, which means that you're already a bleeding risk. So I wouldn't give you aspirin. Vitamin K deficiency. You're already a bleeding risk because vitamin K helps your blood clot. If you already have an ulcer, I don't know if I want to give you, I got to be careful with aspirin because that's going to make it worse or maybe bleed. So there are your used cautiously, right? Non-salicylates. Now we go to acetaminophen, analgesic, antipyretic, right? But it's not anti-inflammatory. And that was a question, wasn't it? It was, right? Acetaminophen doesn't have that anti-inflammatory property like aspirin does, but it will reduce pain and it will reduce fever. That's what it's used to treat, reduce pain and fever. It's great if you're allergic to aspirin, if you have a bleeding problem, or if you're on anticoagulants, if you had a recent surgical procedure, then I can give you acetaminophen, right? If you're on anticoagulants, that was a question. I can give you acetaminophen, right? Right there, bing, bang, and boom. But adverse reactions, ooh, and this is all capital letters, hepatotoxicity. That's the big one with acetaminophen. Hepatotoxicity presents with jaundice and hepatic failure, urticaria, hemolytic anemia, pancytopenia. All those things relate to the hepatotoxicity, okay? The maximum dose is 3,000 milligrams in a day, and there's your antidote, okay? Right there. Don't give it to people if they have liver disease or they use alcohol. Boom, right? Da, da, da. Observe for signs of salicylism with salicylate poisoning, aspirin, vomiting, tinnitus, confusion, hyperthermia, respiratory alkalosis, metabolic acidosis, and multiple organ failure. I should have put in there, and death. Okay, so there's that. And then symptoms associated with salicylates. And this gives you the higher, in other words, if you take a whole bottle of aspirin, you're going to go right into respiratory alkalosis, probably bleed to death, and probably die. Okay. And then the nursing process. Make sure you're giving acetaminophen with a full glass of water, but it doesn't matter, food or not. What are signs of overdose, right? And acute overdose is treated with acetylcysteine to prevent liver damage. Right? And then blah, 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 blah. Oh, discontinue aspirin use 1 week before surgery or dental procedures. Why? Because you could bleed. Teaching on acetaminophen. It's not anti-inflammatory. If they have adverse reactions or if they're a drinker, they better tell their doctor, right? And that's the end of chapter 13. Let's go to chapter 14. And chapter 14, I believe, is the NSAIDs. Let me get to that. And there we are. Chapter 14. That is the NSAIDs. NSAID is non-steroidal anti-inflammatory drug, and migraine, which sumatriptan is in here as well. So what do we need to know about these? First, the drugs that you need to know. right there. Ibuprofen, also known as Advil or Motrin, naproxen, naproxen sodium, which is also known as Aleve, meloxicam is Mobic, celecoxib is Celebrex. Mechanism of action, we don't really know. It just works, okay? But we do know that they're good for inflammatory pain like osteoarthritis, rheumatoid arthritis, and fever reduction. Well, what are the adverse reactions? Big thing, GI bleeding and ulceration with all of them. But look at all the stars after this word, celecoxib. Cardiovascular reactions, in other words, DVT, deep vein thrombosis, stroke, a cardiac arrhythmia, or a heart attack. So if your patient has a history of any cardiovascular issues, celecoxib is not the drug for them, okay? And then I go into the other thing you need to know, Stevens-Johnson syndrome, which is also called toxic epidermal necrolysis. And there's the explanation. Stevens-Johnson syndrome, rare serious disorder of the skin and mucous membranes. Even gave you the explanation, okay? And then I was really nice and gave you the explanation. Toxic epidermal necrolysis, cutaneous hypersensitivity reaction. In other words, short and sweet, cutaneous, right, the skin, hypersensitivity, it's like an allergic reaction, but it's really bad. Macules, which are like blisters, pop up, and they actually can get to the point where the skin is murdered, okay? That's what necrolysis is, necrotic tissue, death to the skin. So that's very bad. And then contraindications. Well, if they have high blood pressure, peptic ulcerations or GI bleeds, the NSAIDs are a problem. But then celecoxib, I put it again, if you're allergic to sulfonamides or history of cardiac disease or stroke, not the drug of choice, right? And then with anticoagulants, real important, because increased risk for bleeding. So NSAIDs would not be the drug of choice if the patient's on warfarin or enoxaparin, any of the anticoagulants, because it's like double indemnity. You're going to have an increased risk for bleeding. And then for the migraines, sumatriptan, Imitrex. What do you need to know? Okay. Cardiovascular system, serious reactions. Vasospasm, coronary artery vasospasm, also known as vasospastic response, which is intermittent chest pain. That's cardiac arrhythmias and tachycardia, which can lead to a heart attack. So it's important to know that, right? And then here, these drugs, don't worry about it, because I know you don't need to know about 5-HT agonists, but the NSAIDs shouldn't be used, especially the COX-2 inhibitors, which is the celecoxib, in patients with heart disease, angina, MI, if they've had TIAs, uncontrolled high blood pressure, or if they're taking MAOIs. Real important. And then here's pre-administration assessment, again with the bleeding. So that's got to be important, right? GI bleeding, NSAIDs, GI bleeding. These are things that you need to know. And the elderly, always remember, the very old and the very young are vulnerable, always. They're more fragile. And so they are going to be a higher risk for bleeding than your average healthy or adult patient. Make sure the patient takes these drugs with a full glass of water and food, because NSAIDs can give you a stomach upset, right? And then I give you some of the nursing process. Why is this important? Because they're going to ask about things like if they have pain, heat for osteoarthritis is a big one. Not rheumatoid so much, but osteo. Rest the joint, don't overuse the joint. I felt like that would be helpful for you. And then we go through the rest of the PowerPoint. Did it work? Well, how do we know? If the pain was a 9 and now it's a 4, it worked. Did the fever go down? Cool. Adverse reactions, were they identified? And does the patient understand what they should and shouldn't do? Here we talk a little bit more about pain assessment, because that's important with NSAIDs and with opioids, which are next, right? So how do you assess pain? I've given you the Wong-Baker-Faces scale. I've given you the Flack scale. And then, of course, you know the numeric scale. And then here are the assessment questions that I gave to help you understand a little more when you're asking questions about pain. What does your pain feel like? Is it sharp, stabbing, burning, throbbing? That's qualifying it or describing it, okay? Does it affect your mood? What over-the-counter or herbals are you taking? Can you take care of yourself? Can you brush your teeth? Can you take a shower without having pain, right? What makes it worse? What makes it better? And here are the guidelines, and I even explained it again. The patient's subjective description of the pain. What does it feel like? You're qualifying the pain. The location of the pain. Where is it? Is it radiating or is it referred? And in the lecture, radiating means that it's going down the leg or down the arm. It's going from where it started and then going someplace else too. Referred means it hurts someplace else that has nothing to do with the actual hurt body part. I'm having a heart attack, but my back hurts. That's referred pain. I have a ruptured disc in my lower back and the pain is radiating down my leg, okay? Then we quantify the pain. We use the scale with people that are awake, alert, and oriented. 0 is no pain, 10 is excruciating, give me a number. Or we use the FACES scale or the FLAC scale for kids or for nonverbal people. And then what makes it worse and what makes it better? What's a precipitating factor? Something that triggered the pain. So if the patient fell and they have back pain, well, the fall is the precipitating factor. That's probably why they have back pain. And then you're looking at the patient's behavior. Are they grimacing, right? And I give even a little bit more here. How are they coping with the pain? And the biggest question that you can ask people, like I write here, can save you a ton of time. Has this ever happened before? Have you had this pain before? Because if the answer is yes, what'd they do about it? Did they find out what it was? Were you treated for it? Boom. And that can save you as the nurse a ton of time and questions. So these are things that I added into this PowerPoint. They weren't there to begin with, but I threw them in there to help you guys out. That's why I say, read the PowerPoints. They're important. And then, is the statement true or false? Patients at risk for inadequate pain management are frequently those who are not assessed well. That answer would be true. If you are not effectively assessing your patient for pain, using some standardized tool always, you're probably not going to have their pain managed effectively, okay? Because the biggest thing, the biggest factor to good pain management is the assessment, okay? And I even write again, quantifying and qualifying. So when you see something repeated like that, that's a hint it's on a test, okay? And that's it for this PowerPoint. And we're going to move into chapters 15 and 16, which are the opioids and the opioid antagonists. Let's go to 15. Chapter 15 are the opioids, okay? So what are the meds that you have to know? Boom. Morphine sulfate, codeine, meperidine, hydromorphone, hydrocodone, APAP, oxycodone, OxyContin, tramadol, and then last but not least, fentanyl. Can be given patch or IV, but the patch, because I talk about it, transdermal patch, slow acting, make sure you have something else while you're waiting for it to take effect. Put it on the skin with the least amount of hair, but don't shave it. Put it on a fatty area, change it every 3 days. Initial and date it when you put it on. Always wear gloves when you're putting it on or removing it. When you're removing it, fold it into itself to prevent the med from leaking out, or from dumpster divers from going into the dumpster and sucking the med out, because that happens. Opioids, they treat pain in the brain. So it changes the perception of pain. That's how they relieve pain, all of them. Okay. What's their use? They treat pain. What are the adverse reactions? Sedation, increased intracranial pressure, respiratory depression, paralytic ileus, constipation, and urinary retention. They're the ones highlighted. They're the important ones. They're the biggies. Who would you not give it to? Well, if they have an airway obstruction or a head injury, be careful, right? Elderly patients, patients that are considered opioid naive, in other words, they never had an opioid before, right? It's a problem. And patients with undiagnosed abdominal pain, hypoxia, or prostatic hypertrophy, which is BPH. So there you go. What do opioids interact with? Antihistamines, sedatives, hypnotics, phenothiazines. There's always an increased risk for central nervous system depression with those drugs. Antihistamines would be like diphenhydramine, which is Benadryl, or dimenhydrinate. Right? Sedatives and hypnotics, sleeping pills, Ambien, which is Zolpidem. All of these drugs cause sedation. So if you give an opioid with them, guess what? Boom, double sedation. Antidepressants, don't give them together because there's a risk for serotonin syndrome. And be careful with kava, valerian, and chamomile, increased sedation risk with those. Okay. See how I have respiratory rate highlighted, but I didn't highlight blood pressure and pulse and pain. You're going to assess them all, but respiratory is important because that's what would make you hold the drug. Because if they have a respiratory rate of 10 and normal's 12 to 20, and these drugs cause respiratory depression, right? You need to investigate further. And then the PCA pump, it's under the control of the nurse. The nurse sets the interval, lockout interval between doses. So if the patient has a PCA pump that's giving them a basal rate of 1 milligram an hour of morphine that they're just constantly getting, then they have the button they can push, and that button will give them a PRN dose of, say, 1/4 milligram of morphine every 15 minutes. That's the lockout. So they can push the button until the cows come home, but the lockout prevents them from overdosing. They'll only be able to get a dose every 15 minutes. And then when we talk about pain meds, the long-acting forms of pain meds, you need a fast-acting form for breakthrough pain. And I highlighted that because that's important to know, okay? And then the nursing process. Report a decrease in their respiratory rate. Anything less than 10, you're worried, or their pulse, or their blood pressure, but respiratory first. And for nursing process, make sure that you're having them cough and deep breathe, use their incentive spirometer. You're not going to keep them bedbound. They need to move, but you're going to provide assistance when they move. Make sure they're taking in plenty of fluid and fiber so they don't get constipated, right? And that is the end of chapter 15. And then last but not least in this group is chapter 16, which are the only one drug, I shouldn't say are, it's the opioid antagonists, and that is Naloxone. Okay, that's the one you need to know. One drug, Naloxone, also known as Narcan. Okay, it's an antagonist. Okay, so in other words, it competes for the opiate receptor sites in the brain. It reverses all the effects of the opioid. In other words, if you were in pain, that's why you took the opioid. If I give you Narcan, you're going to be in pain again. Okay? Without the patient being on an opioid, this drug has no effect, doesn't do anything. The only time you would ever give Naloxone is for an opioid overdose. That's it. What is it used for? Postoperative acute respiratory depression. They come out of surgery, but they don't wake up on their own. Reversal of opioid adverse effects or suspected acute opioid overdose. That's what the drug is for. Like, that's it, the end, okay? But here's something important. If you're administering Naloxone to somebody, say you're walking down the street, or God forbid you have a family member and you know that they're using, and you keep the Naloxone on hand. You give them a dose, you always call 911 because you don't know what they took or how much they took. And the problem is, this is a fast-acting drug and it's going to wear off, and they may die on you again. So you always call 911, and they may need an additional dose. And here I even emphasize that Naloxone's used in PACU after surgery, because sometimes people don't wake up, and we need to give them this to wake them up. And then, is the following statement true or false? People who seldom use opioid pain relievers are termed opioid naive, and they are at the greatest risk of experiencing respiratory depression when administered opioids. They are. Got to be careful with their doses, right? Because we're not trying to kill anybody. And so that was chapters 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16. Da-da-da-da. And I am going to pause recording for Q&A right